meningitis and encephalitis. Key points. Symptoms at presentation can be nonspecific, so early diagnostic consideration, investigation, and empiric treatment is needed. Prompt investigations, including lumbar puncture, together with early antibiotic administration, gives the best outcomes in bacterial meningitis. Herpes simplex virus, HSV, encephalitis should be considered in any child with encephalopathy. Acyclovir should be given to children with encephalitis of uncertain etiology. Background. Meningitis is inflammation of the meninges surrounding the brain and spinal cord. Encephalitis is inflammation of the brain parenchyma. Making a clinical distinction between meningitis and encephalitis is important as the common causative pathogens differ. However, initial empiric management often covers both. Bacterial meningitis is a medical emergency which requires empiric antibiotic treatment without delay. A high index of suspicion for meningitis is needed in any unwell child, particularly if there is altered mental state or no clear focus. Presentation of bacterial meningitis can vary from fulminant, hours, to insidious, days, and can be altered by recent treatment with antibiotics. It is difficult to distinguish viral from bacterial meningitis clinically. Children with meningitis should be treated with empiric antibiotics until the cause is confirmed. Unrecognized HSV encephalitis is a devastating illness with significant morbidity and mortality. However, treatment with acyclovir can lead to a full recovery. Vaccines have significantly reduced the incidence of bacterial meningitis. Haemophilus influenza type B, HIB, vaccine, pneumococcal conjugate vaccine, meningococcal ACWY. Assessment. Red flag features in red. Meningitis. History. Fever. Immunization history. Recent antibiotic exposure. Infant. Minimal or nonspecific symptoms. Irritability. Lethargy, poor feeding. Lethargy or drowsiness. Hyper or hypotonia. Vomiting and diarrhea. Temperature instability. Child, any of the above and/or. Headache. Photophobia. Nausea. Altered conscious state. Preceding URTI may be present. Seizures. Medical condition that may predispose child to meningitis. E.g. CNS anatomical abnormality or shunt. Immunosuppression, immunodeficiency. Examination. Full fontanelle. High-pitched cry. Fever or hypothermia. Apnoea. Neck stiffness. May be absent in infants. Focal neurological signs. Purpuric rash is a late sign suggestive of meningococcal sepsis. Pain and involuntary effort to reduce meningeal stretch. E.g. Kernig and Brudzinski signs. See additional notes below. Encephalitis. History. Fever. Features of altered mental state. Can be subtle and depend on the affected region of the brain. Unusual behavior. Confusion. Personality change. Emotional lability. Seizures, headache. Nausea and vomiting. Consider other causes of encephalopathy, e.g. ADEM, toxins or metabolic. Examination. Focal neurological signs. Management. Blank. Defer if there are focal neurological signs, markedly reduced GCS, cardiovascular compromise, or coagulopathy. Urgent. Microscopy and biochemistry, preferably with simultaneous blood glucose. Based on clinical presentation and initial CSF results, consider further investigations, e.g. multiplex or specific PCR testing for enterovirus, paracovirus, Neisseria meningitidis, Streptococcus pneumoniae, or herpes simplex virus, FBE, may be normal. Glucose, serum sodium, blood cultures. Consider venous gas, coagulation studies if shock or coagulopathy suspected. Consider LFTs, metabolic and toxicology testing if non-infective cause of encephalopathy is suspected. Neuroimaging. Indications include encephalitis, focal neurological signs, signs of raised intracranial pressure, ICP. Diagnostic uncertainty, e.g. to look for a mass. Is not routine in meningitis but is used to look for complications, e.g. abscess, thrombosis. Normal head CT does not exclude raised ICP and should not influence the decision to perform an LP. MRI will provide more detailed information to guide diagnosis, but may require general anesthetic. EEG may be helpful in suspected encephalitis. Treatment. Antibiotics must not be delayed for more than 30 minutes after the decision to treat is made. Blank. Suggested antibiotic regimen, if local guidelines not available. Age group. 0–2 months. Common organisms. Group B Streptococci, GBS, Escherichia coli, Listeria monocytogenes. Rare. Empiric antibiotic. Benzylpenicillin 60 mg per kilogram for 12H, week 1 of life, 6–8H, week 2–4 of life, 4H, and week 4 of life. And cefotaxime 50 mg per kilogram, max 2G, 4, 12H, week 1 of life, 6–8H, week 2–4 of life, 6H, and week 4 of life. Dexamethasone. Not advised. Age group. Greater than or equal to 2 months. Common organisms. N. meningitis. HIV. S. pneumoniae. Empiric antibiotic. Ceftriaxone 50 mg per kilogram, max 2G, 4–12H. Cefotaxime 50 mg per kilogram, max 2G, 4–6H. Blank. If gram-positive cocci on gram stain. Dexamethasone, 0.15 mg per kilogram, max. 10 mg, 4–6H for 4 days. Blank. Common organisms. HSV, Mycoplasma pneumoniae. Other viruses, EBV, CMV, HHV6, influenza. Arboviruses. Empiric antibiotic. Aciclovir 20 mg per kilogram for 12H, and LT 30 weeks gestation, 8H, and GT 30 weeks. Gestation 2 and LT 3 months corrected age. Blank. Or 20 mg, months 12 years. Months 12, or 20 mg per kilogram for 8H, 3. Months 12 years. 10 mg per kilogram for 8H. Consider adding azithromycin. Dexamethasone. Not advised. Steroids. Current evidence for steroids in bacterial meningitis in children is mixed, but does suggest that steroids may reduce the risk of hearing loss. Steroids are not recommended in neonates due to possible effects on neurodevelopment. Give the first dose of 4-dexamethasone just before or with the first dose of antibiotics. If giving the first dose of 4-dexamethasone after initial antibiotic administration, this should ideally be done within 4 hours and not more than 12 hours after starting antibiotics. Ongoing management. All. In the setting of meningitis or encephalitis, should be treated immediately. Consult the blank meningitis/encephalitis guideline to assist with fluid balance. Restriction is often required. Monitor weight, head circumference, vital signs including HR and BP, electrolytes, urea, creatinine, and blood glucose. Isolation, droplet precautions in first 24 hours of admission. Blank. Directed treatment asterisk. Blank. Organism. N. meningitis. Antibiotics. Benzylpenicillin. Duration. 7 days. Organism. S. pneumoniae. Penicillin sensitive. Antibiotics. Benzylpenicillin. Duration. 10 days. S. pneumoniae. Penicillin resistant. Antibiotics. Blank. Duration. 10 days. HIV. Antibiotics. Ceftriaxone/cefotaxime. Duration. 10 days. Organism, gram-negative. Antibiotics, ceftriaxone/cefotaxime, duration, 21 days. Organism not isolated. Antibiotics, ceftriaxone/cefotaxime, duration, 7 minimum days. Organism, GBS, listeria. Antibiotics, benzylpenicillin, duration, 14-21 days. Organism, HSV. Antibiotics, acyclovir, duration, minimum, 21 days. Consider infectious diseases consultation for those with organisms resistant to first-line therapy or with immediate hypersensitivity to penicillin/cephalosporins. Notification. All cases of presumed or confirmed N. meningitis and HIV should be notified to the health department immediately. Confirmed S. pneumoniae is notifiable within follow state guidelines. Complications. Persistent fever after 4-6 days of treatment. Consider nosocomial infection, subdural effusion or empyema, cerebral abscess or parameningeal foci of ongoing infection, inadequate treatment, hearing impairment, neurodevelopmental impairment, multi-organ involvement due to primary pathogen or secondary to septic shock, e.g. hepatic or cardiac, venous sinus thrombosis, seizures, permanent focal neurological deficit, hydrocephalus. Follow-up. All children with encephalitis or bacterial meningitis should have a formal audiology assessment 6-8 weeks after discharge. Earlier, if concerns neurodevelopmental progress should be monitored in outpatients. Consider investigating for complement deficiency if the child has had an GT1 episode of meningococcal disease. Consider consultation with local pediatric team. All children with suspected encephalitis or bacterial meningitis. All children with concern for non-infectious encephalopathy. Consider transfer when hemodynamic or respiratory instability, altered conscious state or focal neurological signs, child requiring care above the level of comfort of the local hospital, complications of meningitis or encephalitis or poor response to treatment. Consider discharge when children can complete for treatment through HITH services if available once hemodynamically stable, afebrile and decision made. Regarding directed treatment,